here.
Okay, we're live on YouTube, so Dr. Bombard, it's all yours.
All right, let's have a roll call.
All right, Patty Bashaw. I saw her.
I see.
Dr. Bombard.
Patty, turn on your mic.
I'm sorry, I am here.
There we
Hi,
go.
Patty.
All right, Patty, I
Dr.
got
Bombard
you. Dr.
here.
Bombard.
I am here.
Dr. Broderick. Dr. Klosser. Dr. Gerling.
Yep, I'm here.
Dr. Cardos. Dr. Katz.
I'm here.
Dr. Morgan. Dr. Pond. Dr. Richards. Dr. St. Jean. Tammy Tromley. Dr. Ventry.
He was here a minute ago. Joe, are you here still?
Looks like he's connecting back to audio. So Dr. Ventry, I'll put you down. Dr. Viscardo. Dr. Weissman. And Dr. Williams.
Here.
All right. Joe Farrell or Mary Ramo. Travis, I got you. Mickey, I see you also. Other guests that I see Eric Catalfamo, Storm Trainer, Vicky Campbell, Bryce Taylor, Paul Zinn, Robbie DeMarsh, Mickey Guy, Scott Harwood. I see a Bruce. Is that Bruce Barry? Or Bruce Mason? Okay, thank you. Anybody else that I didn't call? Or anybody else on that needs to announce themselves?
Dr. St. Jean is listening, but he's working in the ER, but he's available if we need him.
Thanks,
Okay,
Scott.
thank you.
All right, I think that's
All
all
right,
of it.
I guess that's all I have.
Cool. All right. Travis, do you have some ALS operating authority renewals? Or are we up to date?
Well, we have 3 that we're working on. We're waiting on a little bit of additional documentation on. I normally wouldn't hold them back. However, we're trying to get through all of the year-end CME and skills submissions and processing those and updating cards and the database and whatnot. Being Zach and I, we've got 3 to follow up on that we requested info from, but we're going to punt those to April. And we don't have any other requests. We're expecting a request from, I believe it was Queensbury Central Fire. Zach, I know there was a BLSFR that we're expecting a request from, but that hasn't come into my knowledge. So unless Zach has that one, we can move on.
I do not have anything for that one.
Okay.
All right, and I don't think we have Mary or Joe, so we can do education reports. And if anybody sees Mary or Joe pop up, let me know and we'll slide them right in here.
Yeah, I know I haven't, I've talked to Mary especially, but Joe may be deployed right now, and Mary is probably working Surgeon Flex. Everybody at the Bureau is pretty much maxed out right now, so they're probably not going to join us. That'd be my assumption.
I can send Mary an email and just if she has any updates for us, I can just email them out to you guys too. So that's easy. Just in case she has important communications, but I agree. I've also heard that they're working that center a lot over there. So, okay. So Travis, do you have an education report for Mountain Lakes?
Sure. Yeah, I'm gonna keep it fairly short and sweet, just so that the physicians on know that education is continuing, but we have multiple courses that are ending at the moment. EMT courses in Fort Edward and Washington County, an AEMT course over in Granville, which is ending as well. And then we've still got an AEMT course running in Cambridge. And we just advertised an EMT course over in Luzerne, Warren County, which is full. So we're taking a look at that, at capacity and whatnot over there, and trying to determine what to do. We're looking at some possible courses up in Franklin County, EMT and AEMT, and EMT refresher in Queensbury will be announced soon. So usual slate of courses, things are running. We've got 2 AHA PALS instructor courses coming up. So if you guys know of anybody in the hospitals who need them as well, who want to be an AHA instructor, PALS instructor, the first classroom session is tomorrow night here in Queensbury. So it's probably a little too late because they have to do some online work prior to coming to the classroom session. And then we have one up in Plattsburgh, which we just looked at that date earlier. I think it's March 10th, which I believe is a Thursday night. So if you know of anybody who, we have quite a few EMS folks who are signed up, but PALS instructor courses are out there. Certified lab instructor course coming up in Plattsburgh, second weekend in March, as we're also doing a certified instructor update. And then we've got the initial assessment conference in Lake Placid, April 6th to April 10th. That in a nutshell is what's going on education wise. We're plugging along. We've had a few little hiccups here and there with COVID. Somebody gets exposed or somebody tests positive, and but we've fought through it well. The instructors are doing an unbelievable job getting through it. So things are chugging along. Any questions as far as Mountain Lakes education stuff goes?
Hey, Travis, it's Joe Ventry. Now regarding that, but I missed the roll call because I had a technical issue. Just want to let you know I am here.
Perfect. Thank you.
Travis, are you going to discuss with the docs what you discussed with us earlier today?
Sure. Yeah. Sure. So we have this committee from, as far as REMSCO members go. There's a committee that is looking at the future of Mountain Lakes Regional EMS Council from the corporation side of things. So there's Mountain Lakes Regional EMS Council, which is recognized like the REMAC under Article 30 of Public Health Law, that has outlined duties. And then there's the corporation, which holds 2 contracts with the state of New York, and of course sponsorship and the AHA Training Center. And so what we're looking at, we're looking at 2 large components of the operations here. One being what we call program agency services, or the larger state contract of the 2. And a program agency really, although there's a lot of things in the contract deliverable wise, the main function of the program agency is to support the REMAC and the REMSCO. And so we're looking at that contract and trying to determine if we want or can continue to hold that contract. And I say that because, it's a very difficult financial model to overcome and keep operations afloat as you go through contract processes and wait for money from the state. It's a reimbursement type of grant. And then the other piece of it is, like we see with EMS agencies, can there be some efficiencies and, can some consolidation result in efficiencies and, a better product or service for the REMAC REMSCO agencies and providers. And so we've explored a couple of different things. I don't want to go into who we've talked to, but we've talked to some neighbors about potentially merging that aspect of the operation and trying to ensure that there's obviously an entity that is going to service these 5 counties. The other big piece of the puzzle is the education side. And currently there's 4 course sponsors, what the state calls course sponsors in the region. One is Clinton Community College, which services Clinton County. Alice Hyde Medical Center, which does a couple courses a year up in Malone. Ourselves, and then Elizabethtown Community Hospital, and they have the paramedic program through ECH. And then, of course, there's the AHA piece, but our biggest concern is EMT courses, AEMT courses, paramedic courses. And so what we're going to look at as we look at the future of the contracts and the entity is, where does the education piece fit in? How can we create a robust, high quality education system that is stable from a financial perspective? Who's involved with that? And so, what we're going to do is we're going to pull together stakeholders, the county EMS coordinators, the current course sponsors, and at least one additional college, which is North Country Community College, as they've expressed their interest in supporting EMS education. And then we'll probably try to reapproach SUNY Adirondack as well, and just have a stakeholder meeting, if you will, to try to gauge, where the current entities stand, what their future looks like, which entities want to provide EMS education moving forward, and which ones are maybe interested in expanding their footprint, so to speak. So that's what we're gonna look at, hopefully between now and April, and to see what that piece of the puzzle looks like on top of the contract stuff. Does that sum it up, Patty? Do you want to hit on anything else?
No, so I raised the concern that, so we got basically 2 things going on here. So one, the programs, agency part of it is, if depending on where that organization is that, takes us in, we want to make sure that all the parts and pieces of our counties are not getting, are still getting the attention that they deserve, because the more we keep diluting out the availability of being able to get in touch with somebody, or have the agencies have places that they can rely on for answering questions. EMS is already in a crisis. We want to make sure that we're able to hold them up with not diluting it too much. So that's one thing. And of course, the details aren't anywhere near finalized, and we want to, keep that. Everybody needs to have a part in this. So, not only, I think there should be some doctor involvement, or at least making sure the docs know what's going on. And then the other side of it is the education piece. Again, you got North Country. I'm just going to, and this will be like the same. One of the questions came up about Warren County, getting courses. And, Travis obviously states that, Mountain Lakes isn't going away. They'll definitely make sure that the transition is appropriate. But again, we're already behind the 8 ball with not having enough EMS providers. And for us not to be able to provide courses that we don't have to drive like an hour or so to is also really important. So I just think we need to keep the communications open and everybody involved, because if we, dilute this anymore and not have strong agencies to pick this up, as far as like course sponsors and whatnot, I think it's not going to be good. So I think just constant communications is what's going to be really important.
I agree.
All right, Travis, anything else we need to address about that or any support we can give you?
Well, I might be, if everybody's, kind of willing to participate in that kind of stakeholder meeting, as Patty alluded to, I think it's a great idea. So, whether that's you, Tiff, Tom is our medical director for the education stuff. Whoever it is, whoever's interested is definitely more than welcome, and it would be appreciated.
And what the underlying cause to all this is constantly forever is the lack of funding to keep these program agencies and course sponsors in business. I mean, there's just no funding for any of this stuff. So it all trickles down to that. Now, one other question I do have is, Travis, what happens to IAC?
Well, I think that maybe that would probably be, again, I don't want to mention any other entities, but as we're talking with other entities, perhaps that's been brought up in conversation before about some sort of joint effort. So I think there would probably try to be, or we would probably try to ensure that it lives on somehow, through that entity that's going to support the REMAC and REMSCO. That'd be my thought.
Okay, thanks.
Mm-hmm.
So I guess, Travis, I would invite you to just email the docs when you guys are going to meet.
Okay,
and
harass you with email?
yeah,
Sure.
help you out.
Thank you.
Sound good? Yeah.
Yep.
Well, we all get enough harassment emails. One more isn't going to hurt us. It'll be okay. And I think it's important that we're supportive of you guys and that we're in the loop. So let's do that. Okay. Bruce Berry, did you pop on at any point? If not, or Andy Teague from ECH? If not, I
see a Bruce. I'm just not sure if it's Mason or Barry.
I think it's Mason, but I'm not sure. All right.
It's Mason.
Hi, Bruce. Mason.
Thank you.
I talked to Bruce a little while ago. He was going to see a patient in the ER. They needed his help with something. So he was busy for this meeting.
That's okay. I can fill that in. So ECH, the current paramedic program is testing out on February 4th. And they have their registry exam after that, obviously, but that's their class exam. So that's pretty exciting. So that'll be the third go around. And applications should be opening in May or at the latest early June, maybe even earlier if we get approved for the next program, which I believe is starting in July. So that's very exciting. It's a 3-site program right now, the way it stands. So there's a site in Queensbury, one in Lewis, and one in Potsdam. But those are mobile sites. So, although they're fixed for the current class, if we get a ton of applicants from someplace else in the region, we will put a site there. And, let's say we get no applications from Potsdam, we'll just dissolve that site and move it over. So that's the whole beauty of the program, is that it's going to be, the sites are going to be dependent on where the students are. So that's pretty cool. But it's going well. We're learning a lot every year. And we have great participation from all area hospitals as far as clinical rotations go. So thank you, everybody, for helping with that. That's all I have to report, unless anybody has questions about ECH. No? Awesome. Scott, what you got there from Alcide?
No new updates. They're just finishing up a course. They'll be testing out in March, an EMT basic course, and that's their normal course for the year.
Cool. And Storm, what's going on at Clinton Community?
So we're doing our usual basic for the spring, and the AMT course started in November. And so we're moving along with that. I have three students that I've been working with the paramedic bridge, who will be 3 new ones. I think there's still one in Queensbury that Jack is working with. And so I'm hoping in a couple of weeks that they will be ready to do their final practical exam and get on board.
Awesome.
So that's the plan there. So
Cool. Congratulations, Bridge Paramedic. All right. QA/QI. Oh, I'm not sure why I'm reverberating there. Sorry. Somebody from Glens Falls, let us know what's up. Is that you, Tom?
All right, sorry. Hospital-wise, yeah, no real updates at the moment.
Okay. Which one is it, you or Ben, that does the QA/QI down there, or both of you probably, or Doug?
I do it mostly, yeah.
Beautiful.
Yeah.
Anything interesting to report, pointers for us from your QA/QI investigations?
No, we just had an interesting case come in the other day. Patient with MR who came from a DDSO home with a core temperature of 29 degrees Celsius, and he was found inside. So, I'm going to try to reach out to the home and try to figure out what happened there. But it was just, one of those hypothermic cases that, we need to really watch. And, it could, he was profoundly bradycardic, and blood pressure was okay. But yeah, it was an interesting case. So we'll review that later.
Cool. We've had a little indoor hypothermia burst here as well. Okay. ECH, I don't know what their QA/QI guys are doing. That's not me. Is there anybody down there? Anybody that's on have some intel on the ECH QA/QI?
We haven't met recently, so I would say no.
Okie dokie. How about Aliside?
We met last week, and we've been working on stroke and cardiac arrest chart review, and I think it's going pretty well. More active than we've been in a long time.
Good. Anything that you've learned?
Nothing comes to mind, but we have looked at some interesting charts.
We know it all. We haven't learned anything. Okay, good. Clinton County Group. Storm.
So Zach sent me the data for the last 3 months from the state, which is interesting data, but it's extremely difficult to use in any kind of effective means. Originally, I got it as a town, and so we broke it down. He finally sent it to me as an agency group. So it's interesting in that numbers and times and all of that stuff is there. What is not there, though, is the medical data, because it's so widespread. So there are about probably at least 10 ways to code chest pain. So if you really want to research your chest pains and pull those out, without the PCR data, it's pretty hard to be able to figure out what exactly you did. You can actually tell what meds you gave, but you can't pin them to a PCR or pin them to anything. So it's very interesting data. I'm not sure how helpful it is from that standpoint. When we looked at it and we kind of reviewed it. So we're going to go back to asking the agencies to actually delve into their PCRs to give us some meaningful stuff. It's not that I don't want the state data, because I do, but I'd like to be able to marry the two somehow. I'm not sure how successful we will be with that, But it'll be interesting to see what the state comes up with in terms of how they look at the data. Because if they're looking at how many times you do a blood sugar on somebody who needs it, I'm not sure how they're going to pull that data out. Because I certainly didn't see a way to do it with the data sets that I got. So it's a wait and see project, I guess. It's going to take us probably a year before we get it sorted and sifted through and figure it all out. Interesting.
All right. And do we have a North Country group person?
That's me.
Yay.
So we're carrying on, meeting monthly, reviewing interesting cases. There's nothing specific to report, but we remain quite active with good attendance.
Good deal. All right. And Zach, do you have a data informatics update for us?
I don't have much, just a couple of reminders kind of thing. After January 1st, all agencies that are in the CME research program must be submitting PCRs electronically. An agency's status on the CME research program, however, isn't something that Mountain Lakes can see. So I can't actually tell you if all of our CME agencies are already electronic or not. But the paper PCR portal doesn't count towards being fully electronic, so keep that in mind. Other than that, DOH released a new policy 22-01, and that's specifically regarding the BLS first response agencies and their CME requirements. So that can help some of the agencies that have had a lot of questions recently. Other than that, 2020, we had 37,000 ambulance PCRs. Of those, 28,000 were transports. And 2021, we had about 44,000 PCRs, with 32,000 of those being transports. So it's a little bit of about a 4,000 increase in transports and about a 6,500 increase in PCRs. But I think a lot of that is attributed now to we have more agencies that are submitting electronically, so we're able to get more data before. I think a lot of it was paper PCRs weren't really counting in our data. So now a lot of that is being factored in. The numbers that I mentioned only are from ambulance and ALS first response agencies. So that doesn't include any of the BLS first response PCRs. So that would add, a good amount more PCRs, but it's still going to be for the same number of patients essentially. So other than that, I know Storm mentioned she's been getting some data and stuff. I'm going to try to work on some more specific reports, and I want to try to start sending stuff out to the county coordinators more regularly so they can have an overview of their agencies. And that's about it. If you guys have any questions on anything, let me know, but that's all I have.
All right. Thank you, Zach. So CMAC report. We spent a ton of time doing the viral pandemic triage protocol, and I mean a ton of time. It was like eye drying. So I'll address that last, and I'll give you a couple of other updates first. And I just sent out an email with the latest version of the pandemic triage protocol to the docs that are on, and also to Travis. And you guys should have gotten it a little while ago when I first, right after the CMAC, I also sent it out. But Travis, if you could have that on hand and just share your screen in a little bit when we talk about it, that'd be awesome. So things to be aware of that are happening around the state. There's a Buffalo program that's a pilot using using age instead of weight to do dosing for pediatric seizures. So we'll keep an eye on the results of that. I'm sure we all have an opinion on whether that's a grand idea or not. It seems a little scary to me because kids are coming in weird sizes that are not very age-based these days, but we'll see whether they have success with it or not. Maybe it's an easier way to safely approach this. There's also, and this got kicked around quite a lot, There's a pilot out using EMS initiated Suboxone, which might be really interesting to you guys based on, how many opiate overdose patients you're seeing in your regions and what kind of support you have. But the pilot involves paramedics actually handing some Suboxone to the patients. I think it's like 2 or 3 doses that they're handing out. And then they help the patient make an appointment for appropriate follow-up. And the idea is that we are meeting patients at their most vulnerable time. And it might also be the right time to approach them about change. And maybe it's the right soft point to help people actually change their lives. But, if they go back to, now they're in withdrawal, right? And so the first thing you're looking for when you're in withdrawal is to get out of withdrawal. And that means that you're going to go hunting for another hit, right? So if we can give you something safer than your next hit, that's a good deal. So that's out there. It may get pulled into the state or the collaborative protocols. I would be sort of surprised if it does not. So keep your eyes out. And if you want more information and you want to start a pilot, let me know and I will hook you up with the right people to help you do that, because they've done all the work for us. So it'd be easy to do. What else? Just a reminder, there is an executive order that's still in effect that allows our pre-hospital providers to work up to their level of certification inside the hospital buildings. This is a bit of rubbing the crystal ball on predicting the future, but my bet is that that's not going away anytime soon. I understand that there are pluses and minuses to that, right? We're short personnel no matter where you go. And it's a bit of robbing Peter to pay Paul if we bring our providers inside the building. On the other hand, it's a great way to let our providers develop skills and make them a more integral part of our process. So I'll cope with that as we will. Oh, and also a new executive order that is still in effect. Students can take the registry exam instead of the New York State exam. I don't think that's for the basic EMT level, but I think it's for the other levels. Also a reminder, CICs can split a course 60-40 or 50-50 and still get credit for that course. So that's going to help our CICs hang on and continue to contribute to the system. There's an operations center that we were referring to earlier. That's the Surgeon Flex Center. I'm happy to give you the phone number or the email address if you need that. But we should be roping them in if we think that they can give us a hand when we are at capacity as a system. There are, and I'm sure everybody's aware of this, FEMA EMS teams. I think there's 42 of them currently working in the state that are helping with transfers from one hospital to another. They're not doing 911 work to my knowledge, but we are going to all be seeing them in our systems here or there. So just be aware that they're out there and they are a resource. And they've actually helped us here in the upper part of the state quite a lot. They're not always an ALS transport option, but they're generally a BLS transport option, which does help us with some of our patients. EMSC put out a recent survey that you guys should have gotten. Please take a few minutes. It should be like 5 or 10 minute survey. It's a national survey, so it does help them out a lot with direction. And that is about it. So we should just take a quick look at the viral pandemic triage protocol. Travis, do you think you could throw that on your screen and share it, or give me screen sharing? I can do that too. Or did we lose our Travis? There he is.
Zach should be able to facilitate that. You may be able to screen share on your own.
If you could send me a copy, Tiff,
That
I
allows
can put
that?
it up on the screen, or if, oh, okay, there you go.
Can you see me?
Yeah.
Oops, that's the wrong one. You can. Okay, good. So anybody who wants a copy of this, please just email me and I'll email you back a copy. Easy peasy. But this is the latest rendition of the viral pandemic triage protocol. It's currently turned off in our region. But the idea of this, just to refresh your memories, is that this can be sort of an on-off switch protocol. The intent of the protocol is to leave more patients at home safely that have called because of COVID symptoms or whatever the recent or whatever the current pandemic might be. So the idea is that this protocol will give our providers some guidelines towards safely leaving patients at home, whether the patient wants to be left home or not. Right. So this actually allows our EMS providers to say, no, thank you. Very, gently, kindly, politely, no, thank you. We're not going to take you to the hospital today. So it's fairly conservatively written. Again, this protocol is not turned on right now, but the plan would be, Ben calls me up one day and says, hey, we're getting completely overrun down here. We need to triage some of these patients out that are coming to the hospital because they just want their COVID test and they're essentially asymptomatic and they're coming by ambulance. Even just turning off 5 or 6 of these a day will help our ERL out. Let's turn the protocol on. And I say, okay. And I reach out to the rest of you guys and we say, yep, collectively, let's turn the protocol on. My understanding is that we can just turn it on for the Glens Falls area and not turn it on for, Adirondack Medical Center because they're doing fine. The problem obviously is going to be communication more than anything else, not amongst ourselves, but amongst our, from us to our providers. But I think we're doing okay with that as far as I know. I'm sure we would find out if we need to turn this thing on. So I'm sure while I've been chit-chatting, you guys have been reading. I'll give you a minute and stop chit-chatting and let you ask me any questions that I might or might not know the answers to, and then we can move on. All right. Anybody have anything? I don't know how to stop sharing once. Oh, there it is. Okay. So there you go. Throw that in your hip pocket for a rainy day. And that's all I've got from the CMAC report. And we threw the protocol under old business, so that's done. I have nothing. I have no updates about the Moo app. I know some people are using it, some people are not. And it was sort of left adrift. We didn't really tackle that at all this time around at the CMAC. I think we're all sort of tired of fighting over it. We're hoping it'll just be better, but that's all. Does anybody have anything else that we need to address? Because if not, I think I can let you guys go. Travis, remind us when our next meeting is there, my friend.
Sure, I believe it's April 18th.
Great.
Let me check my calendar here. Hold on.
Hey, are you gonna make us some more of those new fridge magnets? I love those. Doug's smiling. I don't know if he's smiling at me in the fridge magnets or not, but there we go.
Hey, Tiff,
Yeah.
do you want to briefly touch upon the destination selection stuff again? Especially after the event that I had?
Well, I have nothing new because I haven't had a chance to talk with the powers that be over there. Though I will on Wednesday. If you have something new, please bring it right up.
It was just more of a reiterating that the closest appropriate facility should not be motivated by institutional financial concerns.
No, it doesn't make the finances do not make facilities more appropriate or closer. No, they don't. You're correct. Yeah, you know what? It's going to be a slow culture shift, but it'll shift.
Zach, do you have the meeting dates handy?
Tell you what, why don't you guys?
I'm looking for him. Hold on.
Yeah, it's okay. I don't have to hold everybody for that. If you guys would please kindly just email out the meeting dates for the year again. I know we've done it before, but a new reminder would be great.
Hey,
And
Tip, I did, sorry to jump in. I did have one thing with the destination topic. It reminded me of an issue we had. So one of our agencies got called to an urgent care recently, and this urgent care was affiliated with one of the hospitals in Albany, and the provider at the urgent care felt that the patient should go to Albany for whatever reason and called Albany Med, got a admit, and then instead of calling a transport agency, called 911. So our local agency arrived there, reassessed the patient, and didn't feel like they needed to go to Albany Med and brought him to Glens Falls. In the end, I think that was the right decision. But my concern was that the provider made that decision and didn't consult with a doctor. And I'm worried that puts them at risk, because then they're changing the medical plan set by someone with higher experience or higher credentialing, whatever you want to call it. So, I was, in the end, it was a bit of a disaster kind of figuring out the details of the plan. But, in the end, the patient didn't need to go to Albany. I don't know why it was determined that they were going to Albany, but my concern was that I didn't want providers making that decision on their own. I want them to call somebody and just discuss that and get our okay. I didn't know if anybody else had any thoughts on that, or similar experiences, or any other bits of wisdom to offer. I'm assuming
From the
sounds like everybody else agrees.
Yeah, we're the only game in town up here, so
Yeah.
we don't have a lot of that sort of problem. I can totally understand how that happened. And it sounds like there's two people to talk to. One was the provider that made probably a good decision, but just needed to loop everybody in. And two is the urgent care person who needed to think about, like, okay, your reasoning is your reasoning, and you probably, thought about that, but calling a 911 service to do a transfer to Albany is also not a great systems management thing. That sounds like someone who just didn't know how to make the machine work. So yeah, sorry, I've got no similar experience to lend you.
Thought I'd bring it up anyway. All right.
We have the opposite problem. All right.
There is
I put the meeting dates in
a
the chat. Sorry, go ahead.
Oh, that's okay. I was just going to say one comment. There is a policy about patient transport decisions. There is a state policy that covers that. And it talks about honoring patients' wishes, if it's reasonable and if it's appropriate in the sense that, you know, they're not going to die by bypassing a hospital. So the policy does have a good balance of honoring patients' wishes with, you know, what's appropriate. So that policy, I can send you that policy, Dr. Williams, if you haven't seen it, but it might help a little bit.
Cool.
Thanks, Travis. Yeah, I'm familiar with that. You know, the patient wishes. I don't think it was the patient kind of making this determination. It was the provider at the urgent care. But yeah, you can send me that protocol. I'll take a look at it and see if there's anything else that would apply.
Awesome. Well, unless anybody else says anything, I think I can let you guys go. Yeah.
Meeting dates are in the chat. Next meeting is April 18th, then August 1st, and then October 24th.
Cool. Can you just email us out a reminder, Zach or Travis?
I will. Yeah, I'll email that out to everybody.
Fantastic. Thank you so much. Well, thanks everybody. You know where to find me.
Okay.
I think I'll let you go. Take care. Be safe.